It's always hard to contend with snack time. So we'll do the best we can. All right. All right. So I have 15 minutes to talk to you about lasers. Can everyone hear me okay? All right. All right, these are my disclosures. I work with a lot of companies that develop a lot of technologies, just like Dr. Smith and Dr. Doe. So take that with a grain of salt. Okay. All right, so we're gonna talk about 3 use cases for laser. We're briefly going to talk about laser for angle closure disease. Very briefly, not a lot of new and exciting stuff there. We're going to spend a little bit more time talking about laser for open angle glaucoma, and then certainly we're going to talk about laser for quote unquote refractory disease. Okay? All right, so before we jump into a conversation about iridotomy, which is really our main laser for angle closure, it's really important to talk about gonioscopy. And I know everyone in this room loves gonioscopy. You never leave home without your gonio. I know you all have it with you, right? But we have to recognize, that gonioscopy is just, quite frankly, poorly utilized. And it is a critical piece of the glaucoma story. If you're not doing gonioscopy, you have no idea what disease you're treating. And doing gonioscopy is not, it's simply, not just doing it, but that's a big burden. Just doing it is important. Doing it properly. We have to do it in dark room settings. We can change an angle from open to close by just turning on the slit beam and allowing that light to enter the pupil. And then we're treating the wrong disease. A little bit of indentation can change a closed angle to open. Just a little bit of pressure. So it's very important to utilize tools like anterior segment OCT, but not ignore the fact that gonioscopy is primary and should be one of the first things we do when we identify a patient who may be at risk of glaucoma or is progressing, or there's a change in their disease trajectory, or you have new information. Any of these things, gonioscopy often. Okay. All right, so who should receive a peripheral iridotomy, right? So this is sort of an evolving world, right? We used to think of iridotomy as a rather ubiquitous procedure for folks with appositional angle anatomy. And certainly in angle closure glaucoma or primary angle closure, which is elevated pressure or PAS in the setting of an iridotrabecular contact, the role of a PI makes sense. But in angle closure suspects, it's still sort of on the fence, right? Will these patients progress to synechial closure or glaucoma or acute angle closure crisis is unclear. And so we have to recognize that PI will relieve pupillary block, but that's it. That's the only thing that a PI is treating. So the ZAP trial, which is one of our landmark clinical trials, has 14 years of outcomes data. It was originally a 9-year study, but there was a 5-year extension. So I'll briefly share a couple insights from that. So again, this is 14 years, but almost 1,000 patients were enrolled. So much more were screened. And the outcome was the development of primary angle closure. So these were suspects that could have gone on to angle closure, which was defined as an elevated IOP ×2, or PAS development, or the development of acute angle closure crisis. All right, so at 6 years, forgive me, I said 9, 6 years, what was seen was the development of an acute angle closure attack was very rare. Okay? An LPI did protect against that, but we're talking about taking a very low risk and making it even lower. So 44 patients needed to be treated to prevent 1 incidence of primary angle closure. And even more needed to be treated to prevent acute angle closure attack, which is the thing that we're most scared of. It's a very rare entity. Now recognize this was done in China. So this may not be generalizable to all patients. We recognize that angle closure is very anatomically dependent. And so different eyes from different parts of the world may behave differently. At 14 years, we saw that the number needed to treat reduced. So you have more time, you have more opportunities for patients to develop angle closure disease. So that number needed to treat dropped to 12. And we have to recognize that most of the benefit of placing the iridotomy was in prevention of synechium. Not necessarily elevated pressure, not necessarily acute angle closure crisis. And even in this cohort, only 1 eye in the iridotomy group and 5 in the control. So very low incidence of acute angle closure. Okay, so the big takeaways here, iridotomy does work in preventing the development of primary angle closure. Acute angle closure is rare even in these eyes. Is this generalizable to our populations? And so who are the patients who get iridotomies in my practice if they're suspects? Certainly if they're glaucoma or they have PAS, we're thinking about iridotomy or even lens extraction. But if they're just a suspect, these are the 4 situations. If they have a fellow eye history of trouble, they have symptomatic headaches or other symptoms that might be intermittent IOP elevations, if they have a very strong family history, or what is probably the biggest utilization, I don't trust them to come back when they're in trouble, right? And those folks, we get a prophylactic treatment. And again, remember, there's a difference between treatment and prophylaxis. A suspect doesn't have a disease. They just might get a disease. So we have to think of these eyes different. All right. And then we also have to recognize that PIs can cause problems, right? So you might be prophylaxing against a disease that they don't have, but giving them a new disease, which is dysphotopsia. So a superior placed iridotomy can cause a horizontal linear dysphotopsia due to the prismatic effect of the upper lid and the tear film. So you get this blue line down below whenever overhead or en face light is applied in some patients. And so I advise that a horizontal meridian iridotomy is utilized. I typically use a nasal one, but temporal is fine as well. This eliminates that risk of that prismatic effect and significantly cuts the incidence of that dysphotopsia. We don't want to be causing problems for patients who don't have one to begin with. Okay, let's talk about SLT. We've all heard about the light trial, so I won't spend too much time. We know that SLT works as a primary therapy. This was a multi-center trial all over, and certainly health-related quality of life, as well as IOP control and risk of need for additional glaucoma surgery, demonstrated that SLT was an effective primary therapy for glaucoma. Again, we recognize that health-related quality of life was similar, significant reduction in need for medications, better pressure on average at more time points, and fewer need for trabeculectomy and less visual field progression. But, you know, that's nice to have great data out of the UK, but here in another part of the world with different eyes and different scenarios, we have to think, again, a little bit more broadly. And so again, we saw some data from the Nigerian experience, and this is data from Tanzania. Again, very different, but some of the same resource constraints, et cetera, that exist across much of the world. And this was an RCT looking at timolol versus SLT. So again, timolol is a ubiquitous medication. It is often first line or at least second line, and sometimes that's the only line from a cost and access standpoint, right? And so what was seen is SLT is undeniably more efficacious than timolol. And these were eyes, one of the big criticisms of the light trial was that was glaucoma light. They're ocular hypertensives and mild glaucoma. Well, this was not. These patients had real glaucoma, much higher prevalence of pseudoexfoliation or advanced glaucoma compared to light, yet it continued to demonstrate its efficacy. Granted, it's only 1 year of follow-up as compared to light's 3 and 6, but at least there's a signal there that demonstrates further the value add of SLT. And again, reducing medications and doing it in a relatively low cost. SLT was effectively the same as 1 year of timolol therapy and had better results at 1 year. So when you get over the initial investment, you are actually providing greater value per unit cost. So what's new with SLT? This is coming, the name has changed. Now it's called the Voyager because it was bought by Alcon, but this is an automated SLT delivery. So it delivers 120 direct shots of laser directly to the limbus, and the laser energy penetrates through the sclera and affects the trabecular meshwork. So I'm gonna move forward. It was validated in a randomized trial comparing DSLT or direct SLT to regular SLT and demonstrated itself to be similarly efficacious. So I'm just gonna go, hopefully this video will play. So you're gonna see an entire treatment of SLT. So we've all done SLT. Most of us have done it or seen it, but this, you see the timer is on. This is the entire procedure. Speculum is placed, some anesthetic is applied. The limbus is automatically tracked by the software. So this is the surgeon's view of the UK. And you'll see the treatment initiated here in just a second. So the limbus is verified, the treatment is started right there. Here's the treatment, 1,000, 2, 1,000, done. SLT is complete, okay? So patient sits back and we're done. Can you imagine? Oh, wow. Yeah, okay. So this is the future. This is the future of SLT, okay? Yeah. Can you imagine? We could just do, everyone's SLT would be done already by the time I'm done with this talk. All right, let's go on. All right.
I know, I would have showed you.
So again, this is coming, guys. This is not, you know, this is not brand new technology. It takes a while to get from, you know, from development through the various processes and actually get into the clinics. But this is CE marked. It is available in Europe. It just got FDA approved in the United States. And part of the vision of the inventor of this, Dr. Belkin from Israel, is to expand access to SLT. And so I'd like to imagine that his mission is aligned with ours here in this room. And I think there's real opportunity for some innovation here. Let's transition to something that's a little bit more old school, which is cyclophotocoagulation. So initially, CPC was reserved for end-stage eyes, non-surgical eyes, blind, painful eyes, etc. But we're increasingly recognizing its utilization much earlier in disease. So I think of this as inflow surgery. We don't really have many inflow surgeries. We have a lot of outflow surgeries because glaucoma typically is an outflow disease. But we recognize that inflow therapies do work. I mean, that's how we treat glaucoma, right? That's all of our aqueous suppression, etc. And so what we recognize is that CPC may have a broader use case beyond those end stage eyes. The specific use case for me was nicely elucidated in the ASSIST trial, which unfortunately enrolled during COVID. So they really massively under-enrolled for their power analysis. But what they were looking at is the utilization of CPC versus a second GDD in patients who had failed their first GDD. So this is a very common scenario we face, right? Where they may have had a trabeculectomy, then you did a tube shunt, and now they're failing that tube shunt. What are you gonna do? You wanna do another tube shunt, which is possible, or do you consider cyclophotocoagulation? What was seen was, granted, relatively low ends, unfortunately, 19 in the CPC arm and 22 in the second glaucoma drainage device arm. But what was seen was similar efficacy, way fewer complications, way fewer office visits when utilizing CPC. So you get the same pressure reduction with a whole lot less work and less cost when utilizing laser compared to a second surgical device. So this is a really powerful procedure. Now, this doesn't mean these are tough eyes. You see a lot of them here, but these are tough eyes. This isn't necessarily generalizable to the mild or moderate patient, but for those specific situations, a CPC may be very appropriate. And in my practice, I utilize, the traditional use case of CPC exists for those patients who cannot bear surgery for whatever complicating reason, but I definitely use CPC as my next procedure after GDD placement to get patients on fewer medications or IOP reduction. And the safety is so powerful, as we see, that even in well-sighted individuals, we can apply CPC and get really good safety and efficacy out. All right, I'm gonna talk really quickly for the last few minutes. You can take a snap of this if you want. I typically use a low, slow setting of 1250 to 1400 milliwatts over 4 seconds. I find that to be less inflammatory and similarly efficacious to the conventional 2000 by 2000, waiting for a pop, then turning it down. We don't need to do that anymore. I think the low, slow works really well. All right, and then briefly, we want to talk about a couple of different laser strategies that are on the horizon here. We have femtosecond lasers, so we can use it to create a hole. So this is a femtosecond laser trabeculostomy. This technology, I'll play the video here, utilizes femtosecond laser to cut a 500 by 200 micron channel in the trabecular meshwork, creating a direct conduit. It's a surgical laser-based goniotomy in essence. But remember, femtosecond laser requires no incision. You dock the laser on the patient's eye, you push the button, it does the procedure, you undock, and the patient goes home. It's a non-incisional procedure that's guided by ultra-high resolution OCT and high-fidelity gonioscopic visualization. And the nice thing about this is the durability of this. It seems to last for a long time. Maybe by using laser, we avoid some of the wound healing challenges of typical incisional trabeculotomies and goniotomies. We can also use excimer laser. So this is another technology that utilizes a miniaturized excimer laser basically on a fiber optic line to deliver focal 200 micron channels that perforate through the trabecular meshwork into Schlemm's canal as well. And so you can see these channels, again, remain persistent for many years. This is a patient who's several years post-operatively, and you can see in this reconstructed CT of an eye that received this, you see very little adjacent collateral damage to the trabecular architecture. So you create this clear punched out hole without any adjacent issues, which may again promote better longevity of that outflow channel. And so we see some persistent efficacy. This is in FDA clinical trials right now, so we don't have access to it, but this technology has been available in Europe for many decades, even into the 90s. Right. So this is not necessarily new, but hopefully we'll see continued innovation in the laser space. Sorry for talking so fast. I'm still behind, but
thank you, Professor Shah. Move on to Professor Adiola Onokoya. I done the introduction before.